Hi class, here again with objective 3 from module 3 and 3. And without further ado, let me share my screen and get that objective up there. All right, well, we're going to describe and evaluate several school and community-based programs that are public health programs, meaning they're looking at broad populations as a whole and trying to largely prevent substance use. All right. Well, first off, I want to talk to you a little bit about how one might test a program to see whether it's effective. This is really, really important, and you probably heard about this in some other classes. A randomized control trial. That's when we take a population and we give one group the treatment or the prevention program in this case, and we give the other group some other kind of program, and then we observe the outcome. So you know about this idea of the experimental and the control condition. And I want to remind you that when we test these programs, we always randomly assign two conditions. And that is where you see that roll of the dice there. That refers to random assignment. We randomly assign so that group 1 and group 2, the group that gets a treatment, and then the group that doesn't get the treatment or gets some other treatment, are equal in almost every respect. That's super, super important. We don't want a whole bunch of women in one group, a whole bunch of men in another group. We want to make sure those groups are equal. So in the end, if the outcome comes out differently, if our treatment really did help, for example, delay substance use over the control treatment, then we know that it's not because of some other factor there. Okay, so I'm going to talk to you about some programs that have been tested and that are looking really good in some randomized control trials. Okay, first one is Life Skills Training Program, and this is a school-based program. It's for elementary and middle school students. So these are generally pretty young kids, and it's intended to prevent the onset or delay the onset of drug, and when I say drug, I mean drug and alcohol use. So it's about 24 to 30 class sessions over 3 years. So it's a relatively long program. Because of that, it's kind of ends up being rather expensive. But it deals with a lot of different kinds of skills. So life skills there is important. It's going to build skills in certain areas. And one of them that directly relates to drug use is drug resistance skills. How do you deal with social pressure? What happens when, because inevitably for these kids, certain things are going to happen. Other kids are going to be drinking, or someone's going to be drinking around them and offer them some, and same with drug use, right? But then it goes beyond that into some personal management skills and also general social skills. And the thought here is that people who have good skills in these other areas, for example, coping with challenges in their lives, coping with stress, good social skills, ability to meet people, make friends, talk to people, talk to diverse others, overcoming shyness, those are important toward drug resistance because they allow the kid to deal with a lot of their issues. You know what I mean? And it's kids that who tend to be lonely and isolated and things like that, who are very susceptible to drug use. So in dealing with some of these other problems, it makes them more likely to resist. It turns out there's pretty good evidence for sustained effectiveness. And by sustained effectiveness, I mean, they go through the program, and then even for months and months afterwards, we're seeing a reduction in drug and alcohol use. And again, that's through these randomized controlled trials, which are very, again, just the number one standard for seeing if anything is effective. Okay, another program that takes a different approach, but also is very effective, is a program called Guiding Good Choices. And this is for parents of preteens. So again, we're looking at pretty young kids, not kids that have generally started using drugs yet. And this is a parent skills training program. So it's going to be working with parents, not with kids directly. Presumably, the parents then work with the kids. But the idea is to teach parents some of the kind of protective things that they can do to help their kids be resistant to drug use. And it's going to really focus on creating some very strong bonds for the kids, creating strong bonds primarily with the parents, but also with schools and with peers. And the parents can facilitate that. It's 5 2-hour sessions over 3 days. So compared to the last one we talked about, life skills training, it's a lot less involved. It's a little bit easier basically to teach the parents, and then the parents are putting in a lot of time to the kids. So when it comes down to it, this is a lower cost program. It has been shown to be effective in randomized controlled trials in improving parenting behavior, so that just people can become better parents. They're managing their children better. They have more positive relationships with their children. And get this, over 3 years later, they are still seeing effects with regard to alcohol and drug use. So, for example, the kids are less likely to have ever been drunk, to have ever smoked marijuana, or to have used alcohol in the past month. Again, compared to a control treatment condition. So that, we know this program works. We know it works, and we know we can reduce drug use in communities if we use these programs. But hint, hint, we'll see in the future the program's not used very much, unfortunately. Another really good program that's been effective is called the Project for No Drug Abuse. And that's for teens age 14 through 19. And they'll have 12 40-minute sessions. And the difference with this program and some of the other ones is that rather than sort of teaching, lecturing, you got a lot of interactive activities and games involved in that, and that seems to work really well. Now, remember, these are a little bit older kids, so some of them are already using, and some of them are not. It works on skills like we saw in the other program. And also because the kids are a little bit older, it can work on some kind of like a little bit more complex cognitive stuff. For one is motivation. And that's this idea that, a lot of times people think, because of who they're surrounded by, oh, everyone does drugs, oh, everyone smokes weed and things like that. And in fact, it's actually very few people who do relative to the larger population. But the perception that everybody does it actually motivates people to do it more. So correcting some of these perceptions, this idea that drug use is okay or doesn't have any harmful effects is another one. And that's particularly, that may even be modeled by parents and things like that. And then we see, just similar to the life skills, social skills, self-control, that some of these more basic skills seem to make kids resistant. Finally, decision making. You can imagine talking about some of the decisions that might facilitate drug use. It turns out to be actually pretty effective in preventing substance use, although I don't think it's been tested out as far as, say, guiding good choices. But at least initially, it seems to prevent substance use, and it also seems to be good for violence. So for reducing violence in communities. So this is another good program that's been shown to work by multiple studies, good quality studies. So we know that prevention works. We know that we can reduce drug use in a community, before the problems start. So that we don't have so many people who are addicted to drugs. But unfortunately, it's not used very often. And here's the problem. Some of the problems with that is that, schools are the obvious place to put it in, public schools. But not a lot of those schools are using evidence-based programs. And some of it is that the school officials don't really understand, the concept of testing with randomized control trials and how those are the better tests. Instead, they'll a lot of times be swayed by a program that's got flashy bells and whistles, and they say, oh, this works for, 60% of kids or whatever, but we don't know what would happen if the program was not there. Maybe 60% of kids would have never tried drugs anyway. It's just not a very good test. But nonetheless, we have people that are not very sophisticated about the experimental methods, who are making these decisions. oftentimes, even when they do use an evidence-based program, the delivery is often poor because they don't have the training, or there's a lot of turnover in schools, where new employees are coming in, and it's just hard to get programs up and going. So I want to suffice it to say that new practices are implemented very, very slowly. We're getting a little bit better, but politics have played a role, and they especially played a role in the past. So we'll talk a little bit about it historically, because the most commonly used program, you probably know what it is, ever in schools to prevent drug use is called DARE. And unfortunately, DARE was like an epic failure. It stands for Drug Abuse Resistance Education. And what it was when police officers who were trained to do this program would come in, and they would teach kids decision-making skills about drugs and about gangs. And it was done, you got to kind of look, it came into existence in 1983. And this was the Reagan era. The war on drugs was up and going and strong, right? And there was a lot of fear. And there's fear in the schools, there was fear among parents, and DARE came out as like, this is the panacea, this is what we need. We need to tell kids, police officers telling kids how bad drugs are and blah, blah, blah. So it grew hugely. From 1983 to 2009, it was in use, and it was over, 80% of schools for most of that time, and sometimes even up to 90% of schools were using the program. So if you went to school during that time, you will know that you saw DARE in almost anywhere you were at in the country. Unfortunately, it wasn't until the 1990s, like I said, it came into existence in 1983 and spread quite rapidly. But in the 1990s, these researchers got there and said, hey, this hasn't even been tested. We don't even know if it works. So they did some randomized control trials, and they found that it didn't even decrease drug use at all in these kids. There were no studies showing that it actually decreased drug use. And even worse, in some studies, it increased drug use over the control condition. So that is disastrous, basically. That's disastrous. We certainly don't want to, there's one thing to be saying do no harm by using something that doesn't work, but this was actually doing harm. So anyway, politics come in because the schools have invested very, very, very heavily in this. And, the programs were all in place, and many police officers were trained and all this stuff. So anyway, these studies come around, they say, hey, this stuff isn't even working. And then DARE, the program, said, oh man, we better get it together and find something that works. So there was a program in existence, and it was called Keeping It Real. And it was a program that had some evidence behind it that it worked. It was a decent program. It wasn't used very often, but it had some evidence behind it. And it used a lot of interactive stuff, like the Project Toward No Drug Abuse. It was a decent program. And it was billed as being culturally sensitive, and meaning that it appealed to minorities. And you can see, we probably call it more like cultural appropriation now with the name Keeping It Real, but whatever. It was seen as a culturally sensitive program. So it worked. It was culturally sensitive. Keeping It Real was the name of the program. So DARE partnered together with Keeping It Real, and they created a version of Keeping It Real called DARE Keeping It Real. And all the schools that were using DARE just basically adopted DARE Keeping It Real. So what the Keeping It Real DARE version was still more culturally sensitive than the original DARE. It used police officers. So the original Keeping It Real did not use police officers, but the DARE-ified version of it did use police officers. They kept in a lot of role play though, and not just lectures. So they put kids in these situations, have kids practice their skills. That was good. It's used actually currently in about 75% of school districts. So it's still really, really popular. So the popularity of DARE just transferred to Keeping It Real, which is not a bad thing, because Keeping It Real actually works. It's more effective than the original DARE. It's not necessarily as tested or as effective as some of these other programs, but at least it works. And it's not, I'm just think of the many, many years we spent on DARE, and it wasn't even working effective. It was harming in some cases. So So keeping it real is better than that. Okay, I'm going to talk a little bit about community interventions. This is when a whole bunch of diverse community groups, maybe law enforcement, churches, schools, parents, get together and they partner to reduce alcohol and drug use in the community. And they can do lots of activities, and there's just an unlimited number of things you can do. But a given community intervention will usually have a number of different activities. Here's some examples. Increase the law enforcement on sales to minors. Warning basically convenience stores that we're going to be sending in some actors here who are minors, and you better be carding everybody because you won't know who those people are, and that will get people carding all over the place, and which is good, because again, if we can delay the onset, that makes a difference. Door-to-door promotion. You can promote events door to door, billboard advertisements. These are things like you probably seen social norm kind of advertisements, like 80% of MU students don't binge drink or something like that. Smoking cessation classes being offered in a community for people who want to quit smoking, free classes that they can come, that they can get nicotine replacement therapy and things like that, in the form of the gum or a patch or whatever. Increased DUI monitoring, that's driving under the influence, sobriety checkpoints, things like that, beer keg registration. These are all things communities can do to reduce young people's drug use, and then also, well, even with older people, smoking cessation, things like that. Okay, well, I'm not going to talk about specific community interventions. There are many that have been tried in communities, but I want to talk to you about some of the things that make them effective. As I mentioned, they can be effective, and they have been effective, and randomized control trials have found that they, in fact, are effective in many cases, but the size of the effects are small. So the cost is really an issue there, because if you're spending a huge amount of money for a tiny little effect in reducing drug use, well, maybe it would be better to put your money somewhere else where the effects are a little bit bigger. So cost is an issue. If it's a very low cost program, then it makes sense that the effects are small. But if it's a high cost program, the effects being smaller are disappointing. And so it seems that effective programs have three things in common. They have a community mobilization, so it's a lot of different groups in the community coming together from broad areas, as I was mentioning, religious groups, school groups, law enforcement, all coming together. And they're doing two things. They're educating, but education alone doesn't seem to promote effectiveness. So just educating people, for example, about the dangers of drugs. I mean, that's probably really where DARE went wrong, is that they did that, but that wasn't really enough, And so where we saw, teaching social skills is important. Here in the community interventions, policy change is important. So changes in the way that, for example, beer keg registration is a policy change, right? When you get a beer keg, you have to say where that party is going to be at, where it's going to go. Okay. So as it turns out, for effective programs to work, it's better if they are locally originated. So for example, if you're going to do a program in Kansas City, that the stakeholders in Kansas City, the police department, the religious groups, the this and that, they are the ones who develop the program, because that will give them a lot more investment in the program. If you just import a program from elsewhere, it tends not to work as well in the local community. They know their own challenges. They know what they're dealing with. And so those effective programs are more likely to be locally originated. Okay, the takeaways from Module 3. Public health plays a really important role in understanding and preventing addiction. We got the surveillance piece that tells us what's out there. If we understand what's out there, we can then create policy that changes those things. Prevention is really key in a public health model, because we're not treating people who are already addicted. We're creating fewer problems for the future. We're getting people before they get addicted. It really highlights the importance of environmental factors, where the disease model that we've talked about before, really, we're looking at a person who already has an addiction and we're saying, oh, they're the problem. They've got a disease. Or the moral model, they're the problem. Now we're looking at whole communities. Where is a place where substance abuse is more likely than elsewhere? And why? There are effective prevention programs out there, and public health has been really good at testing those programs. They really rely heavily on experimental methods to test those programs. But unfortunately, the programs are not widely implemented. And so that is the big challenge of public health, is how do you get those programs out there and get them to be used right and get people trained right in the programs so that we can reduce drug use in the community. I hope you guys have a fantastic day, and I will see you next time.